Hello, everyone. Happy Friday. Welcome to Friday RLR. Except we have an update today. It's not RLR, it is RLM. And yeah, L is a strong word for somebody you've known for a year and a half or so, but I think it's really fundamentally true. I get the pleasure, and those of you who are logging on know this already. Um, I didn't realize that the email was updated to actually include the names of the case presenters. So I thought I was doing a secret intro of who's discussing today, but I'm very, very excited. Um, I'm very, very excited to let you all know that I get to share the spotlight with Mark today. And I'm a little distracted because our case presenter just showed, and so we were having plan B as a backup if our case presenter wasn't able to be here, but I think we can go back to the original plan. And the original plan of introducing Mark was to tell you all that Mark, we were talking about you yesterday. By we, I mean a bunch of CP Solvers people, and you just came up as in a part of the conversation about how it's incredible how the CP Solvers identity, it seems to be to the people outside of them, outside of the institution, sort of fixed, and it's like a group of people who love clinical reasoning. But I think there's some people who actually morph and change the identity of CP solvers. And the more and more I interact with junior people in our academy who are early in their journey, the more and more I hear the words like, I want to be like Mark, I want to be like Mark, I want to be like Mark. And it's incredible. I mean, I think it's incredible to think about what you've been able to do and how much you've been able to change this landscape in CP solvers in such a short period of time. And to become a role model for anybody in medicine is a huge honor, but I feel like it's especially so when it's a bunch of people who are so dedicated to being great doctors. And so for them to look up to you is really, really cool. I'm glad I'm starting to get a little unemployed in CP solvers, which is great. It's part of why we do these RLR episodes is when Reza is on service and no longer able to make it. We try to honor people who really have become synonymous with the word CP solver. So I'm super excited to discuss this case with you, Mark, today. I'll hand the mic to you to say hi, and then we can go ahead and introduce our case presenter.
As always, you guys are way too kind, and I don't say this lightly. And just like you guys are the ones that really push me like every single day, and I truly, truly mean that. I talk about you guys all the time on words, and you guys do really drive me just to just be better every day and just take the best care I can possible for the patient. So thank you guys. But yeah, I'm gonna really miss Reza today. But yeah, I'm really excited about this case.
Amazing. Oh, we made him blush. I don't know if you noticed. Saw a lot of rumor there. Before we introduce our esteemed case presenter, I'm so excited to see here. I just wanted to give a big shout out to the two people who are making it happen and hear their voice before we hop on. The first is Zakaria, who's actually presenting the case next week and volunteered to sub in today if needed. But I'll hand the mic to you, Zakaria, to say hi and update us on what your week has been like.
Hi everyone, I'm Zakaria. It's been a good week, a bit busy. Saw a case of a Legionella pneumonia that patient needed to go to the ICU and be intubated. That was quite cool. And yeah, looking forward to the case.
Incredible. Yeah, I love I'm sorry that happened to the patient, but I'm glad that they were under your care. That is not an easy diagnosis to make, and I hope the patient has a speedy recovery. I'm glad you got to learn from their journey. Also taking care of patients in critical situations is Anmol, who has been working in the ER. Anmol, what's new with you?
Hello, everyone. Very excited to be here. I'm always excited to do the teaching points. I've been working hard in the ER, that's true. And I'm hoping to present some of the cases I see there. So very excited for today.
Incredible. Well, I think that the only person who might make me a little bit more nervous than you presenting a case on Mole is Hugh, who is our case presenter. We got to know Hugh a little around a year or so ago when he came and presented an incredible case of Lemire syndrome, and so I've never forgotten that, and I'm very, very excited that you're here again, Hugh. Hello.
Hey guys, nice to see everyone again. I'm so excited and just absolutely, as we say here, absolutely gassed to be here. There's I have, as you know, I've been a fan of this podcast and this VMR for a long time. And I was teaching some students and some junior colleagues of mine earlier in the week, and kind of spend 20 minutes talking about how much I love this podcast and how they should all get involved with the clinical problem solvers and the VMR. So yeah, delighted to be here and present a case.
We're very, very happy to have you, my friend. It's been a while. We're excited to see you back. How are the last few months treating you? What have you been up to?
Yeah, things are good. I am applying for a rheumatology specialty training here in the UK. So I guess I'll find out in the next kind of days to weeks if I have an interview for that. But in terms of non-medicine things, I got married in September.
Congratulations.
Yeah, and my wife is still hasn't left me, so it's excellent, really.
Oh,
I'm hanging
great,
in there, guys.
great news all around. Speaking of wives, my wife is also going to rheumatology, and so we have that in common, is surrounded by very, very cerebral people. That's really cool. Well, congratulations on getting married, and I think any program who can recruit your intellectual might should really take the opportunity. So I hope you get an interview, and I hope we get to hear your we go from you presenting cases on RLR to you being a subspecialty discussant on Monday VMRs. That'd be a wonderful arc to see. But yeah, why don't we hop on in and hear your case?
Okay, all right. Brief word of warning. I think the beginning of this case, there's quite a lot of context I think I need to provide, but I think we'll just start with a very brief opening chief concern. So this is a 51-year-old female who presents with progressive limb weakness, bulbar symptoms, and respiratory compromise. I will then give you a little bit of context. So by the time that this patient attends our hospital, she had actually been unwell for about 1 month. She was diagnosed by her GP with Graves' disease. That was 1 month ago. And she saw an endocrinologist at that time, and she started carbimazole and propanolol for Graves. She was being managed as an outpatient. Then 2 weeks ago, she attends a different hospital with quite vague symptoms. So she has fatigue, bilateral lower limb paresthesia, and she spends a week in hospital while they try and work out try and find an underlying diagnosis. During that admission, she has an MRI of her brain and her spinal cord. She has nerve conduction studies, and she has a lumbar puncture. And all of these tests are essentially negative. She has nothing, so everything is negative. There's nothing that indicates she has either a central or a peripheral nervous system pathology at play. She's got no thyrotoxic myopathy, they didn't think. And her paresthesia, it actually just spontaneously improves during the admission, and she's discharged. And that's the end of aliquot 1.
Oh my gosh, wow, what an emphatic start, and very, very yeah, there's a lot of data here. I'm curious, what crossed your mind, Mark? Where's your head at?
Yeah, I just wanted to ask one clarifying question. Hugh, when was she diagnosed with Graves' disease? Was this 1 month before 1 month before presentation?
Yeah, exactly. So 1 month ago, Graves' disease diagnosis, starts treatment. 2 weeks later, develops this paresthesia and significant fatigue, has lots of investigations in hospital, and is discharged. And her presenting complaint to the hospital today is that she has limb weakness, which is new, bulbar symptoms, and respiratory compromise. So she's feeling breathless.
Thank you. Yeah, Rabih, I think as I progress through my training, I've developed a very healthy level of skepticism, I think, especially with like patients' past medical histories. So I think that, there's some conditions which are very easy to, like there's a test or there's an imaging result where you're like, okay, they have this, we confirm this. But some conditions are more nebulous, say like HFpEF or COPD that we see in one-liners very often. I think Graves' disease is usually pretty straightforward. I definitely would check for the thyroid stimulating immunoglobulins, the TSH, just to make sure that we have the right diagnostics here, especially because this patient is coming in with a very peculiar syndrome. So I'm just going to assume those were done, right? And then, as we saw in a VMR recently, I think it was either yesterday or the day before, we do a lot of things to patients that cause harm. And I don't mean that in like a negligent way, more so like medications that we give, patients that have a lot of side effects. So keeping it back in my mind, the two common medications we give for Graves' disease are, like methimazole. It sounds like this medication is probably a cousin to methimazole, if I heard it correctly. Carbimazole, is that? Yeah. Okay. So it's probably, similar, and a really devastating side effect of some of these medications is agranulocytosis. And patients are warned that anytime they have a sore throat, a fever, or any signs and symptoms of infection, to go to the emergency room to get a stat CBC with diff. I don't know if I could exactly tie that to what's going on right now, but I would definitely want a CBC with diff and make sure this patient didn't have agranulocytosis, because that could really open up the infectious bucket. Because patients with neutropenia, especially deep neutropenia, can have pretty peculiar common and uncommon infections. They also can get liver injury, as well with methimazole. Those are kind of the two, big side effects of those medications. And then propranolol, we prescribe a lot of beta blockers. I think this is probably not related. Patients on beta blockers can get fatigue, but definitely neurological symptoms would be completely new for me for beta blockers. So that's kind of like the patient's background history. I would say that if I was, I'm admitting today, and if I saw this exact same patient coming in with, that had acute onset, lower extremity paresthesias, neuropathies, the typical neuropathies that we think of, B12 deficiency, diabetic neuropathy, neuropathy associated with HIV, alcohol use, right? Those are more subacute to chronic bilateral symmetric polyneuropathies. This course is moving pretty quick. I'm very worried about this patient. Guillain-Barré syndrome, or AIDP, is definitely would be like a first consideration for me, because we would need to treat that and evaluate for that pretty acutely and pretty quickly. But this patient got a nerve conduction study, a lumbar puncture. It sounds like an MRI that was negative. And the one thing I'll say about this is that I've also developed a healthy level of skepticism for tests. In general, most tests are not perfect. There's some tests like biopsies, which might be close to perfect, but for instance, like immunocytological dissociation for Guillain-Barré syndrome is pretty insensitive. I wouldn't rule out Guillain-Barré if your lumbar puncture doesn't show a high protein and normal cells. But I kind of think of nerve conduction studies as pretty good. But again, I think no test is perfect. And then, this patient presenting now, Guillain-Barré works its way up, right? So Guillain-Barré starts in the legs classically. There's a beautiful review article, I think it was in the Nature recently, that kind of goes over all the different subtypes of AIDP. Some are sensory motor, some are motor predominant, right? Most patients have hyperreflexia with Guillain-Barré. But there's these other syndromes like the Miller-Fisher variant that can work its way up pretty quickly and cause cranial nerve issues, usually ophthalmoplegia and ataxia. But given this patient, what was the symptom that I was latching onto for the cranial nerves things? I'm blank. Oh, the bulbar symptoms. So I'm worried, is this a acute neuropathy that's making its way up? Or is this kind of unrelated to what I was previously saying? And then other causes of like acute, neuropathy, you can think of like heavy metal toxicities, lead, mercury, all those, and like something like acute intermittent porphyria. There's not many things that cause acute neuropathy. It's usually toxin mediated. So I'll kind of stop there. I don't want to. Yeah, I'll kind of stop there. We can maybe talk about the bulbar symptoms and stuff either now or later. But yeah, what do you think, Rabih? I've rambled a lot.
No, I think there's a lot of reason to like have a convoluted arc to the story, and I think that you're by having a thought process that doesn't feel organized or linear is, I think, symbolic of what is happening, because the story is not linear at all. And I think you taught us a lot about the distrust that you should have with tests, and also how to approach this patient who's coming before you now. And the only thing that I will make note of is how little time you spent talking about central causes of this syndrome and how much more time you spend talking about peripheral causes. And I think that's a very, very powerful thing to latch on to, is that when patients present with respiratory compromise, which is presumed to be diaphragmatic weakness in the context of bulbar symptoms, I think you can quickly make the leap that, hey, when somebody has respiratory compromise in the context of a neurological syndrome, I'm going to worry about diaphragmatic weakness. And then if you open up a schema anywhere, including on our website about diaphragmatic weakness, you'll find that central causes are actually pretty uncommon. And the central localization for diaphragmatic weakness is in the cervical spine. And so, of course, when you think of bulbar symptoms and the cervical spine, you might think of brainstem disease extending into the cervical spine. But the vast majority of causes of bulbar weakness and respiratory compromise are actually outside the central nervous system. with the one exception being subarachnoid disease that infiltrates the subarachnoid space and compresses on those nerves in a microscopic manner, like infiltrative sarcoid or TB basilar meningitis. So I want for folks to really emphasize the leaps and the amount of time you spent thinking nerve, neuromuscular junction, muscle, way more so than central causes. And I think that tends to be a very powerful variable for bulbar weakness. And I think that also intersects well with the performance characteristics of diagnostics tests for central versus peripheral nervous system disease. If you really compare and contrast the tools that we have to diagnose central nervous system disease versus peripheral nervous system disease, in general, and these are broad generalizations with many, many holes in them, in general, peripheral nervous system disease tend to be more diagnostically difficult and more diagnostically evasive than central nervous system disease. So you went into great detail, and all I am supplementing is the 10,000-foot view, which reinforces what you said. If you have a patient with bulbar weakness and respiratory compromise, odds are for a peripheral localization. If you have a cryptic neurological syndrome that has evaded extensive diagnostic testing and you don't know what the localization is, I think it's much more likely for the peripheral nervous system testing to be falsely negative than central nervous system testing, which is why I think all the thoughts that you generated about nerve, neuromuscular junction, and muscle are exactly where I'm at. Alrighty, Hugh, I'll pass the mic to you to give us a little bit more.
Right. Sorry about that very convoluted start, but I think it's
Great.
important to have a bit
Real
of
life.
a window. Yeah, exactly. Yeah. Okay. So second aliquot. So she's now represented to the hospital today. Since leaving hospital last time, 2 weeks ago, she's started to feel profoundly weak. So in the last 3 days, she's been too weak to even walk from her bed to the bathroom without her husband half carrying her. She's continued to lose weight despite having a high-calorie diet. She's noticed that it's difficult to swallow and can only tolerate small portions of food. She denies any sensory loss, any bladder or bowel dysfunction, or visual change. She is prescribed carbimazole and propranolol, as mentioned. She has no allergies. She has never smoked. She doesn't drink alcohol. Prior to the last 3 months, she had been independent and she used to cycle every day. She works in an office setting. She lives in a very suburban environment, and there's no recent history of foreign travel. She has no family history of note either. And that's the end of that.
Wow, you went in deep on the first aliquot and much gentler on the second one. Thank you. I'm sweating a little bit less and less now. Awesome. Thank you, Hugh. Yeah, Mark, what happened to your initial thoughts here with this additional data?
Yeah, sorry, Hugh. I asked a lot of questions. It's mainly because I just try to clarify the problem, which the CP solvers have taught me. And when you say weak, like, does she identify that it's mainly leg weakness or is it forelimb weakness?
Yeah, so it's lower limb weakness, I think, is the predominant symptom. She cannot lift herself and she cannot walk without help. I think it's the most startling thing. Yeah.
Yeah, I mean, this is not an uncommon. I would say the previous hospitalization, what's happened during the last month, definitely is a little more uncommon. But I'll just kind of like, for now, approach this in a silo and just kind of approach this lower limb weakness. And this is a very common symptom I see in the hospital all the time. Some patient maybe comes in for lower limb weakness, falls, and there's kind of a way that I usually approach it. I mean, most commonly, patients will have lower limb weakness because they have maybe lumbar disc disease, right? They have they have lumbar disc disease. They might have radicular symptoms. So I usually always ask, like, do you have any, like she had 2 weeks ago, but any, paresthesias, any numbness, any radicular symptoms, any back pain, something to give me a clue that this weakness is coming from the back, because that's very common. I'm very glad that you asked about bowel or bladder symptoms. In situations like this, I'll always get a bladder scan because while history is helpful, I think very cheap and easy test to do, or you should just do them despite the history. Because if this patient has urinary retention and doesn't have a history of urinary retention, I'm like, ooh, I'm really worried about that lumbar spine, and it would really kind of rush me to get an MRI of the lumbar spine, especially if that wasn't done in the last admission. So that's kind of the lumbar spine. And then again, like, neuropathy, right? Again, this is kind of an atypical, it seems, atypical neuropathy, but I'll ask any numbness, any tingling, do a good neurological exam in terms of, if I was good at like, doing the temperature, all those like test all those types of sensations, which neurologists are excellent at. That's exactly what I would do. And then also thinking of more maybe uncommon causes of bilateral lower extremity weakness. You could think of bilateral central etiologies of any kind, right? Maybe this patient has, a tumor that's kind of in a very unfortunate position that is causing her legs to be weak, or, maybe an embolic phenomenon to both sides of the brain that is causing her limbs to be weak. I did just see a patient recently, about a week ago, that had just a classic presentation, which can be hard to diagnose sometimes, of just severe cervical stenosis, where their main presenting complaint was lower extremity weakness, but they didn't have any really radicular or neuropathic symptoms, and they were just falling a lot. So it's always important to remember that to scan for, is there any upper extremity symptoms, at all that they're having, numbness, tingling, dropping things that can give us a hint that this is not just in the lumbar spine, this is also maybe in the thoracic or cervical spine. And if we're getting a hint at that, right, most common things is just like degenerative disease, spinal stenosis, but with everything else going on, could this patient have a transverse myelitis? Could there be a mass in the cervical spine or somewhere in the spinal cord? So that's kind of like how I approach it. I think the neurological exam is going to be very helpful, especially with reflexes, especially with the bladder scan, especially with upper extremity reflexes as well. Because if we're moving towards scanning the patient's spine, I want to decide if I want to scan the whole spine or just the lumbar spine. So that's kind of what I think about. I'll kind of leave the weakness there. Maybe the patient is having some other symptoms too. But yeah, Rabih, what do you think?
Yeah, I think that I think this is a profound space that we're in, and I'm literally arriving at the same conclusions you're at. And my journey has been colored by a really eye-opening case that Aaron presented to Reza and I on RLR CP Solvers, where the patient, just like this one, had head to toe symptoms. And I think that really this is a long-winded way of getting to exactly where you are, Mark, but I was thinking about that case a lot, which I won't go into too much detail, but this person can't swallow, can't breathe, can't walk, and yet is able to tell you all that. And I think that contrast between how dysfunctional her limbs are, but how functional her brain is, has profound localization value. And so if you ask yourself, could this be in how could this be in the central nervous system? I think that anywhere in the cortex, the subcortical structures, the cerebellum, it's impossible for her to have this much devastation and not have any central cortical symptoms, movement disorder, mood changes, so on and so forth. So what is the localization here? I think it is spinal cord or below. And you mentioned very early how cervical stenosis can easily fool you. So if you're going spinal cord and then nerve roots, nerves, neuromuscular junction, and muscle, if I really try to simplify this and take a lot of leaps based on the history about where this is, which of course will be reinforced by the exam, I think the lack of bowel and bladder symptoms is a big hit against the cord itself. So if we go cord, nerve roots, nerves, neuromuscular junction, muscle, I think the presence of sensory symptoms is a strong argument against a pure muscle process. So what are we left with? We're left with nerve roots, nerves, and neuromuscular junction. The presence of sensory symptoms would not be very compatible with a postsynaptic neuromuscular junction disease like myasthenia gravis, which basically presents very similar to a myopathy, except the pattern is different. It's usually in the eyes and in the upper extremities rather than the lower extremities predominant. So I think the localization here is either this is nerve root issue, nerves, or a presynaptic neuromuscular junction disease like Lambert-Eaton syndrome. But why is Lambert-Eaton syndrome less likely? The patients with Lambert-Eaton syndrome have a profound autonomic dysfunction, with almost 100% of those patients having dry mouth, dry eyes, erectile dysfunction, GI dysmotility. And of course, that could be present, but camouflaged by the sheer compromise in her limb function. But you would expect that by the time Lambert-Eaton is affecting the bulbar muscles, that there's been prominent dysautonomia, because it usually actually begins in the limbs and goes up, in inverse of myasthenia. So I think with just the history alone, the localization here is nerve roots versus nerves. And you might ask, well, what's the point of the distinction between nerve roots and nerves? The nerve roots really remind us that you can have infiltrative subarachnoid disease that can actually compromise all the nerves quite simply. You can have all the nerves go offline by a diffuse disease that affects the nerves like heavy metals, or the easiest and most elegant way to shut down every single nerve in your body is to have them be infiltrated and infected or compressed as they course out of the lumbar spine, as they course out of the cervical, thoracic, and lumbar spine into the body. So how can you have head-to-toe nerve disease? Head-to-toe. I think it's either an infiltrative subarachnoid disease, which will show up on the LP. And if the LP is negative, this is a diffuse nerve disease. And I think it's very, very rare that you encounter a patient with head-to-toe symptoms. But if there's head-to-toe symptoms with intact sensorium, I think the key diagnostic test, in my opinion, is a lumbar puncture to see, are you dealing with an invasive subarachnoid disease? And if you're not, then I think you're dealing with a very advanced, devastating neuropathy, which has a small differential diagnosis. So I wanted to see, I want to see how that lands with you. It's the first time I'm articulating this thinking out loud. I've just been reflecting in my head, honestly. This is the first opportunity I've had. So I'm curious what thoughts or questions or any holes in that attempted articulation, Mark.
Yeah, no, that was awesome. And it kind of generates some things in my head too. I think one thing that is very odd is that why did this patient get better? Well, why did this patient's paresthesias and all these transient bulbar symptoms that get better and then they came back? That's very odd. I can't think of a situation that I've encountered of this devastating neurological symptoms that got better and then came back like this. Unless it was a transient process. And the one thing I'm just trying to layer in the patient's like background. There is this rare entity of thyrotoxic periodic paralysis. I think this would be a pretty atypical presentation of it, but usually those patients are hypokalemic, and that's partly why how the paralysis is mediated. There's a ethnic distribution to it. I'd be curious of the patient's potassium. Again, I think it's probably a lot less likely. I think it's more just like paralysis, as the name describes, and not as much bulbar symptoms. I'm sure it's possible. And then, like, anytime I'm struggling with the time course, we talk a lot about, localization, or sorry, when I'm struggling with the localization, because there's just so many things going on, I just always think about what connects, just the body in general. And like, could this be a multifocal process? And a lot of times when we think of multifocal process, we think of embolic phenomena. But like you said, like an embolic phenomenon, especially if it's embolizing to the brain, and this patient's giving us such a rich history, that just like patients that, that I've seen with septic emboli or any time to emboli to the brain, they are confused and usually not doing too well. And wouldn't be able to give this rich history. But then also I'm like vasculitis, but this just doesn't seem like it's giving a vascular footprint. But just kind of when I'm thinking multifocal processes, that's kind of, and the classic multifocal disease, that being multiple sclerosis, but the time course is largely just incompatible with this. But yeah, that's kind of things that came up.
So many questions to answer. I love it. I think all those are very, very awesome thoughts. Yeah, Hugh, we're very, very intrigued. I'm sure you were when you first met this patient. What do you have next for us?
Cool. So let's get to the examination. So first, some observations. So saturations are 98% on room air. Respiratory rate is 18 breaths per minute. Blood pressure is 126/81. Heart rate is 110. There's no fever. Respiratory, cardiovascular, and abdominal examination are all unremarkable. Examination of the skin is nose and throat, don't reveal any obvious abnormality either. Neurological exam. So cranial nerves. Although there is no obvious ophthalmoplegia at rest, the patient does complain of diplopia in multiple directions of gaze. There is symmetrical loss of muscle bulk noted in both arms and legs. There's no fasciculations. Tone is normal throughout both upper and lower limbs. I'll try and keep the rest of this simple. So the upper limbs, there is symmetrical 4 out of 5 proximal weakness bilaterally. Distally, from the knee and elbow down, normal motor function. So there's a proximal weakness only. Sensation is actually intact. Coordination is also intact. So to summarize, there is 4 out of 5 arm and leg, hip girdle and shoulder girdle weakness bilaterally, 4 out of 5. Her gait assessment. So she requires assistance to rise from lying to sitting, and also from sitting to standing. And she needs significant support from 2 people to walk just 10 steps in the department. We did a forced vital capacity at the bedside, and it was less than 1 litre, at which point we transferred the patient to intensive care. We placed an NG tube and an arterial line, and that's the end of the aliquot.
Oh my gosh, the severity of how sick this patient is amazing. Very profound. Mark, I think this is a great opportunity not to steer your thinking, but I think to share with folks how you're thinking about her respiratory compromise with her O2 sat, and why is Hugh moving her to the unit despite her O2 sat being normal and her respiratory rate being normal? What is that disconnect there?
Yeah, I would say that if you got a venous blood gas, and with this patient's history, that's one of the first tests I would order in the emergency department in terms of, triaging this patient, how sick they are, and their disposition. I would guess they're probably pretty hypercapnic because, when you have diaphragmatic issues and you can't ventilate, you hold on to CO2, right? So this is not a oxygen exchange issue. This is a ventilation issue. So until there's, this is getting into the weeds of like physics, I guess, or chemistry, whatever subject, but, you can be pretty hypercapnic before you become hypoxemic. I think it's one of those laws, maybe Bohr's law, one of those laws. But I think here it's just worried that as the patient becomes more hypercapnic and becomes more acidemic, they're going to get confused. And then when they get confused, they become more hypercapnic, and then they're not going to have the inability to protect their airway. So that's one of the, in patients like this, we always get a forced vital capacity to see how much can they move their diaphragm, and it really helps us to know their trajectory. There's kind of different. We do like a sniff test and see how much power they have in their diaphragm, and there's certain numbers that you can always look up, but that can kind of tells us what are the next steps in terms of managing this patient.
I love that. Thank you for outlining that so clearly. I couldn't have done it better myself. What happened with the rest of the data for you?
Yeah, just starting with the vitals, because vitals are vital. Luckily, this patient's blood pressure is looking good. They're tachycardic. Anytime someone's tachycardic like this, always get an EKG to confirm it's sinus tachycardia. In the background, this patient does have, new Graves' disease, and is on propranolol, and presumably they're taking the propranolol. So this, I worry that if we didn't have the propranolol on the board, this patient might be tachycardic to 130s to the 150s. So just keep that in mind. Anytime the patient is not tachycardic, and I think they're tachycardic or they're tachycardic, I just scan their med list and see if they're on any AV nodal blockers, because that could really kind of change like that calculus. But I'm wondering, does this represent the Graves' disease that's maybe not adequately treated? Or is this our hint to dysautonomia? And really, like tachycardia, bradycardia is really the first sign of dysautonomia. You don't have to be hypotensive. You don't have to be hypertensive. Really, the heart rate usually goes first. And then kind of layering in the exam, I think we're starting to gain more clarity, right? Anytime we have like a proximal muscle predominant syndrome, it's usually a myopathy or a neuromuscular junction issue. And usually, honestly, myopathies are usually silent, usually their main manifestation is proximal muscle weakness. And then in my experience, the rest of their neurological exam is pretty benign. They might have other systemic features going on, right? Say someone has dermatomyositis, they have a rash, they have a cardiomyopathy, they have dysphagia because of their, esophageal muscles isn't working that well. But like the rest of their neurological exams, sensation, all that is usually pretty intact, especially early on. But when someone starts to have these like proximal muscle weakness, has all these bulbar symptoms, and I get concerned about neuromuscular junction disorders. Most classically we think of myasthenia, which you brought up now, whether the numbness that the patient had 2 weeks ago is related to what's going on, I assume probably so. It'd be very atypical for myasthenia to have sensory symptoms. And also this time course is pretty quick for myasthenia. If I'm remembering correctly, I want to say beta blockers are on that medication list that could, if I'm remembering, could potentially trigger a myasthenic crisis. Antibiotics are on that list as well. But I think maybe that was the precipitant into a myasthenic crisis. I still think, you kind of mentioned Lambert-Eaton syndrome, which is usually perineoplastic in nature. So I would definitely, if we think, that's at play, we would kind of search for a lung focus or a lung cancer. And then I think the one I always forget to think about is botulism. And, classically, I don't know what the sensitivity of this is. I would definitely look it up because most things that we learn in like medical school that are classical presentations are pretty insensitive, but usually is a more descending process. Could it be ascending? I'm sure it could. So I definitely would consider that in this patient. And yeah, I think the GBS and GBS-like syndromes are still at play, especially with the dysautonomia. Not the classic AIDP, but some of the subtypes. But yeah, I'm really worried about this patient. I'm glad they're in the ICU and getting really intensive care.
Yeah, Mark, I'm right there with you, and I'm also really, really worried about this patient. And I think that I too started with the proximal muscle weakness, and I think if you just layer on statistics, proximal muscle weakness equals muscle disease in the vast majority of patients. However, it's not 100%. So how can we organize everything else? And actually, what happens is the further you are from the muscle, the less and less likely you are to present with proximal weakness. So what's the second most common localization for proximal muscle weakness that isn't muscle? It's neuromuscular junction disease, be it Lambert-Eaton or myasthenia gravis or even botulism. What's less likely is nerve diseases, but there have been cases of ALS that present with proximal muscle weakness, CIDP presenting with proximal muscle weakness. So a nerve localization is totally plausible. And so what are the arguments for each of those three categories, nerve, neuromuscular junction, or muscle? I think probability would say muscle. The presence of diplopia would suggest neuromuscular junction disease, and the presence of atrophy in the arms would prioritize nerves. So everything is fair game. And I think that the tension in this situation is the diagnostic testing for all those things is going to take some time. What do you do now? And if you actually ask yourself, what is the common denominator for treating myasthenic crisis and treating aggressive nerve diseases like CIDP or Guillain-Barré? And we can talk about the time course here, especially if the history is this prolonged, is not in keeping with AIDP. But the thing that might be on a neurologist's mind is, do I institute empiric IVIG or plasmapheresis in this patient? Do I institute empiric pyridostigmine in this patient? So as you said, she's very, very sick. This is very likely an immunological phenomenon, be it on immunological muscle disease, immunological neuromuscular junction disease, immunological nerve disease. So I think empiric treatment might be something to think about here. The only caveat is the caveat that you mentioned, is that she has a neurological perturbance along the thyroid axis. So I think a TSH a TSH abnormality might push you to deviate from that empiric IVIG pathway, but it's, I think, something that folks would be thinking about. So I think to summarize, proximal muscle weakness suggestive of muscle, but also compatible with NMJ or nerve disease. There's a hint for all three. Probability says muscle, diplopia says NMJ, and sarcopenia says nerve. When it all really comes down to where is the lesion, of course, but when somebody's this sick, you might think about empiric IVIG. But I imagine there's quite a bit left to this case, so let me hand the mic to Hugh to give us some more information.
Cool. I'll start to hurry up a bit, guys. Sorry, I'm really longing this out.
No, not at all. It's very, very interesting. There's a lot to think about for sure.
I can't wait to talk about this at the end, because it's so interesting how, I don't know, it's so interesting how in a different you know, someone else's shoes and hearing how other people approach things. You know, did I think about this wrong at the time? Let's find out. So the hemoglobin was 170. A white cell count is 9. Platelets are 320. CRP is 1. Sodium 135. Potassium 4.4. Urea 5.6. Creatinine 57. Calcium is 2.5. Albumin is 39. Creatinine kinase is 621. Troponin T 137. TSH 0.1. Free T4 19.3. Anti-TPO and anti-TSH antibodies are both clearly positive. So the anti-TPO is 117 and the upper limit of normal is 34. The anti-TSH receptor is 2.09 and the upper limit of normal is 0.4. ANA and ANCAs are negative. Tumor markers are negative. And that is all I have for this aliquot.
Maybe I can just clarify, because the units are probably different. Do you mind telling us what was abnormal on her basic labs?
So her hemoglobin is probably slightly disproportionately high,
Okay,
which at the time we thought was just her volume status.
yeah,
Her U's and E's are actually normal. So her creatinine, the way we say
Yeah.
it, would that's normal creatinine for us.
perfect. And the calcium and all that other stuff is normal too?
Happy days, all normal.
Awesome. Okay, alrighty. So Mark, what happened there for you?
I definitely always feel a little more comfortable when the labs come up as opposed to the neurological exam, because I love labs. But yeah, I mean, I don't think we're overly surprised. I really was keeping a close eye on some of the electrolytes, especially the potassium, with that, you know, hypothesis of maybe, but less likely, thyrotoxic periodic paralysis. And again, I think the mechanism really of that is hypokalemia. So I think, you know, it makes it a lot less likely. Although a lot of these like periodic paralysis syndromes are very intermittent, and you might, however, that means their neurological symptoms are usually intermittent. So if their potassium is normal, they really shouldn't be having like devastating neurological symptoms. So I think that makes that a less likely. Glad we got a calcium, as it can cause neurological symptoms. And then we have a mildly elevated CK, which honestly, as I order more and more CKs, I feel like it's becoming almost like a liver injury or AKI in the hospital. It's like so many patients that come in, if we get a CK, we'll just have a mildly elevated CK. We have a decent reason, you know, Graves' disease can cause a little bit of myopathy and myositis. So whether that's actually related to the neurological signs, the neurological symptoms they're having, it's possible. I mean, it's hard to ignore when we talked about one of our highest things on the differential is a myopathy. And then I'm just thinking about what cause of myopathy or myositis can act like this and be so hectic and crazy and progressive. You know, things like antisynthetase syndrome or MDA5 dermatomyositis. Those usually have a very prominent extra neurological footprint, whether they have rashes. MDA5 dermatomyositis causes terrible, rapidly progressive ILD. They usually do a lot outside of the CNS. And again, this is very much like predominant in the CNS. So while we can consider those, and I feel like more and more I read about dermatomyositis and like its subtypes, like it can do a lot of things and present very atypically. So you can consider setting a myositis panel, but it just, I think the TSH or the CK probably could be explained by the Graves' disease. And, you know, anti-TPO, as we also think it like just associate, you know, think about it associated with Hashimoto's and hypothyroidism. A large proportion of patients with Graves' disease also have TPO antibodies. And I don't want to bring this up again, but like thyrotoxic periodic paralysis is also associated with TPO antibodies. But I think that's just probably representative of this immunologically mediated thyroid disease that she has. So I don't know if honestly I was paying close attention to the potassium and some of the electrolytes. They're normal. I was curious about the CK. It doesn't move the needle too much for me. So I don't know how much progress. I didn't think my pretest probability for the labs helping me out was too high, unless the CK was 10,000 or something. Yeah.
Yeah, I'm right there with you. I think the progress we can make is to really like say this is a neurological, a disproportionately neurological disease with, I think the threads to reassess in the future are, what does that polycythemia represent, and what does that CK represent? And I think right now, I think in real life, you're really interested in the localization exercise to know what problem you're trying to solve. And I think unlike before, when the only symptom was paresthesias, she now has profound weakness. And so I think the yield of the EMG is probably going to be much higher in the current clinical context as it would be beforehand. And so, yeah, I am right there with you. Disproportionate neurological disease, we can revisit the hemoglobin and the CK, but only really, I think, to make productive progress after the EMG or other data that might elucidate it better.
Cool. Okay, so next, Aliquot. So within 24 hours of admission, we managed to get an EMG. It was an EMG of her right deltoid and her right orbicularis oculi muscle. There are clear inflammatory myopathic changes on the EMG. There are widespread fibrillations indicating muscle splitting and a myopathic pattern of motor units and recruitment. The neuromuscular junction studies are normal. We also got a myositis panel, which lots and lots of antibodies sent. There was one which returned positive called anti-Ro 52. Everything else was negative. And we also sent an autoimmune neurology panel, all of which was negative.
Intriguing. Mark, what you got?
Yeah, I'm a little surprised, for sure. Maybe I'm not. I guess that like I said, even though that the proximal muscle weakness is very classic for myopathy, I just think that there wasn't too much going systemically for a myopathy. I mean, there's more causes of myopathies definitely than, immune-mediated myopathies like dermatopolymyositis, antisynthetase syndrome, or the overlap syndromes. Like a lot of the myopathies can have an overlap with lupus, they can have an overlap with mixed connective tissue disease, and all those. But, there's a larger differential, for myopathy in general. I'm curious about still going back to the time course, and honestly just staying true to like some of the first things we talked about, right? This patient did originally present with honestly, I'll just describe it as an acute neuropathy. And I'm wondering if some of the heavy metals, I don't have a great illness script for a lot of these heavy metals like mercury. Lead I know a little more about. I think this would be pretty incompatible with lead syndrome, but cobalt, like all these things, I just don't have the best illness script. I would test for them honestly, and just in real life, just be looking them up online if this could be compatible. But I'm curious if they can cause like a prominent myopathy. There's nothing that's coming. I would love to hear from you, right? But there's nothing that's coming to my mind right now. But again, that's just like a hole in my knowledge right now. But kind of just going through myopathy, I talked about the immune-mediated myopathies. You can have metabolically associated myopathies, right, with thyroid disease. We talked about thyroid disease. Again, it's still in the back of my mind, especially now that I think about it. Hugh, did you mention that the TSH was like it wasn't at goal, like the TSH?
The TSH, let me just give you the number. It was actually, 0.12. So under the lower limit of normal. It's not raised.
Gotcha. And what was the free T4? Was the free T4 really high?
No, it's 19.
Okay. Gotcha. What is the upper limit of normal in your lab? Just curious.
So 14. So it's not crazy high.
Okay. So possible, but probably not what's causing this like devastating syndrome. And there's genetic myopathies, right? Storage diseases, all those things. But in a 51-year-old, seems very highly unlikely. So yeah, I think where I'm at right now, I guess now that we have the EMG that shows the myopathy, I honestly, again, the patients can have as many syndromes as they want. So I still think probably need some, neuroimaging to assess the neuro axis. But I definitely would be sending these, heavy metal screens. The myositis panel, I definitely have some associations with some of the antibodies. Ro 52 is not one that comes to mind right now, but I would just look it up in real life and just see that, is it one of the myopathies that can be this rapidly progressive? Again, classically MDA5 is the really rapidly progressive one, but hey, maybe Ro is also one of those as well. But yeah, Rabih, I'm very curious to think, especially about if this could be compatible with like a heavy metal toxicity.
Yeah, I think that I think that it's just to illustrate to everybody the power of the EMG here. If you ask yourself, well, what is the most momentum gaining test? I think it really is that EMG. It tells you this is a muscle problem. And I think the overlap between heavy metal disease and neurological conditions often localizes to the peripheral nerves and less so to the muscles. You ask yourself, like, what makes people really, really sick from muscle disease? And I think that it really is two categories, endocrine and immunologic. And so I think that when you have somebody this sick from a muscle issue, you might then say, okay, is there an endocrine element to it? And I think the endocrine element has been historically very profoundly suggested with the presence of Graves' disease. But now do we have to revisit that and say, hey, this person has a myositis and a panel that's positive for it, for something. And actually, I don't know enough about anti-Rho 52. I've heard of it here and there. But I think the practical question now is, you got a really devastating muscle disease and you got evidence of a positive antibody. And I think I would probably take that to define my problem and say, do I need to biopsy the muscle here to get further clarity? But that may reflect a knowledge gap on my end. But is it time to start empiric treatment? Because I think this patient's so sick from this process. So I think that, you now have a syndrome of really advanced severe muscle disease, which could be endocrinologic, but I think as you've outlined, we've assessed that very, very thoroughly, and that doesn't seem to be gaining momentum. And so you're left with the most common category of devastating muscle disease, which is an inflammatory myopathy. And so, I'm probably at the limits of my knowledge in terms of what I'd be thinking, but I think the only things that I can think might be helpful are an MRI of the muscle, a muscle biopsy. But I do think that my instinct is I don't know how to connect this with the Graves' disease apart from just immunological activation. And I'm really curious to learn how he was thinking of it and how he took it forward.
I mean, I'm stunned again at like how you were able to digest any of this. I found this case particularly overwhelming. I'll give you a little bit, just a few lines on the patient's progress, and then reveal some further investigations. So at the time that the EMG came back, the working diagnosis then was that this was myositis with bulbar involvement, diaphragm involvement. And the patient was started on methylprednisolone and IVIG. And despite that, in ITU, her ophthalmoplegia was starting to become more apparent. Her forced vital capacity fell further, so it dropped to 0.7. And at that point, her arterial blood gases were showing type 2 respiratory failure, and she was intubated. This all happened quite quick, within 48 hours. For the next week, she remained intubated, and despite the treatment, there was no progress. We started rituximab for refractory inflammatory myositis while we were waiting for other investigations, and we decided to organize a muscle biopsy. So here are the results of the last tests and the muscle biopsy. So it was a right deltoid muscle biopsy. The histopathology reveals clusters of inflammatory cells surrounding necrotic fibers, and there's evidence of muscle fiber phagocytosis. Immunofluorescence shows disruption of the neuromuscular junction and the acetylcholine receptor architecture. There's no evidence of metabolic or mitochondrial muscle disease. The patient's, some further blood tests came back at this stage as well, just a few days later. So her acetylcholine receptor antibody level was nearly 20. And to give you an idea, the upper limit of normal is 0.4. So it was stonkingly high. Her muscle-specific kinase antibody was negative. So that's the anti-MuSK. An MRI of both femurs showed some mild active myositis in both thighs. And an MRI, the last test we organized for her was an MRI thymus, because we had a constellation of Graves, myositis, and then possibly also now, the lights have gone, and also another third illness, we thought. And the MRI thymus shows cystic hyperplasia on T2 weighted images. And that's the last aliquot. I'm just going to turn the lights on.
I think it's so ominous that the lights went off, Mark. Oh my gosh. It represents exactly what's going on in my brain.
Very dramatic. Yeah.
Yeah, Mark, where are you at?
Yeah, this is a wild case. Thank you. This has been an awesome journey. Yeah, I mean, we talked about myasthenia, in the beginning, and a lot of these things can have overlaps, especially myositis and myasthenia. There's a really good New England Journal review article on myasthenia, and it talks about how myasthenia is associated with autoimmune diseases like lupus, and so I wouldn't be surprised. And again, another thing I've just looked up in the real life is myasthenia also associated with myositis, because classically, like, you wouldn't think of myasthenia causing myositis. If you had just really severe myasthenia, then you probably would have a myopathy if it just was so destructive. But this is the evidence of a myositis. So I don't know if I would directly attribute the myositis to myasthenia. It'd probably be a more of an overlap syndrome. Because again, patients, especially in rheumatology, patients can have all of these overlap syndromes. So it's always really nice, especially on VMR, when we can kind of wrap something neatly into like one diagnosis. But honestly, it probably fits really well with maybe a myasthenia with a myositis overlap syndrome. And maybe the reason the patient didn't get better with, I think it was IVIG and steroids, which, does treat myasthenic crisis, but maybe they just needed a higher dose immunotherapy because they had, two syndromes going on. Needed like rituximab. As soon as you said like steroids worsened, I was like, oh, I'm still keeping botulism in the back of my mind. I still think that's like highly unlikely, but just another NMJ disorder, because we keep talking about NMJ disorders. But yeah, I think, especially with the thymus, the cystic hyperplasia, I think that's right there. That is like, objective evidence of the relationship between myasthenia and its pathophysiology, and then also other autoimmune diseases. But yeah, Rabih, what do you think?
Yeah, I'm right there with you. I think what I'm curious in terms of plugging my knowledge gap is what the sensitivity of an EMG is for a simultaneous muscle and neuromuscular junction disease, and what happens to the ability for the EMG to detect neuromuscular junction disease if there is concomitant parallel muscle disease. And does the muscle signal dampen and reduce the diagnostic yield of a neuromuscular junction disease? And so I think, if we go back to the original kind of framework that we became confident in about proximal muscle weakness, I think that it becomes really telling to say, well, we had neuromuscular junction and muscle. And I think when you have such advanced, devastating muscle disease, the atrophy can happen. And the diplopia is not because of muscle disease, but rather neuromuscular junction disease in the form of myasthenia. And I think that, Mark, if this patient had received immunotherapy, then I think a very clear syndrome would emerge called the triple M syndrome: myocarditis, myasthenia, and myositis. And I actually did some reading after that condition was presented on VMR and learned that it can also happen spontaneously without immunotherapy. And so I'm right there with you. I think this is an overlap syndrome, and I think that we know that it can happen spontaneously. We actually had a case of an overlap syndrome of a patient who had Lambert-Eaton and who had myositis. So the overlap between neuromuscular junction diseases and myositis is a fascinating space that's well described as you outlined. And I think we probably have to really escalate the treatment for this patient, including potentially a thymectomy, potentially as a rapid restoration of immunological tolerance. And at the same time, keep an eye out for her heart, and to really make sure that the last M isn't something that's sneaking under your radar, especially with the tachycardia that she had, and now that she's intubated and may not be able to report chest pain and whatnot. So very, very humbling evolution to learn with complete surprise that you can have myasthenia sneak under an EMG. I thought EMG was a really good tool. I'm really curious to learn either from Hugh, if he knows, or later on about that. And now making sure that we don't let one other thing slip under our radar, which is potential cardiac involvement in the triple threat of the third M, myocarditis. Hugh, what you got?
Oh, wow. Yeah. Thanks so much, guys, for your comments. I think the first thing to say is that this patient had a really, really good outcome. after the acetylcholine receptor antibodies came back, pyridostigmine was started in intensive care. Also, another dose of rituximab was given, and very quickly after that, she was extubated successfully. Her ophthalmoplegia resolved a few days later, and we did actually take her case to the thymoma MDT, and the decision was made to go for thymectomy. This was months after. So her follow-up in a clinic a month later, she was doing really well. She's still living independently, and is kind of getting towards a full recovery. She's still on treatment for Graves. She is still the last I heard, she had another dose of rituximab, and after her thymectomy procedure, the histology from the thymectomy was consistent with the thymoma, which was like this is by far the most like mind-blowing, confusing case I have ever been involved with, and just delighted that you guys were able to interpret it in a way that I just couldn't at the time, and delighted for this patient that she had such a good outcome.
Oh my gosh, I think that this is as discombobulating and as complex a case that I can recall on VMR, and I'm not the least bit surprised that you brought it to us today. But before I ramble, I'd love to hear your thoughts, Mark. You have your hand over your head processing this case.
I'm going to tell my team that I will not be accepting any more missions today. I cannot, my brain cannot handle it. Yeah, and no, thank you so much. It's so great to hear that the patient did well. And I'm wondering if the propranolol also was again, the patient did have actually, I guess they didn't have neurological symptoms before the propranolol. So I wonder if that was a trigger, for the myasthenia. And yeah, I think a case like this always remind me of and I tell this to my learners all the time, it's so important to know your test characteristics, not something that I think is really taught or emphasized well in medical school, but knowing the sensitivity, specificity of really all the tests that we commonly order for, so for example, I have no idea I assume too, Rabih, that the EMG is really good for myasthenia, but I wouldn't be surprised if we looked it up and it's 80% sensitive and, there's a 20% hole there. Or that's why when we got the acetylcholine receptor antibody, it's my understanding that it's almost 100% specific for myasthenia. So it's okay, good. We at least have one answer. But I wouldn't be surprised if the row, I mean, I guess in this case, patient has myositis, but some of these a million myositis antibodies that we send, if they're probably not 100% specific. And Andrew has a great tutorial on this antibody craze syndrome, where some diseases just trigger all of these antibodies to be positive. So I just think it's really important to know the test characteristics, especially when you're interpreting a complex case like this. So thank you so much. This is awesome.
I couldn't agree more with those reflections. I would love to pass the mic to you before we learn from Anmol, but if those questions crossed your radar with you and your team about what happens with the EMG and sort of lingering things.
Repeatedly, there was loads of theories thrown around, particularly when we had, I think before the acetylcholine receptor antibody came back, which took a long time, we were really kind of just, we were in the dark. And when the acetylcholine receptor antibody came back, suddenly we were starting to think about these, just like you said, Mark, these overlap conditions. And I remember reading around that time, that year, about these, immune checkpoint inhibitor medications that were causing these overlap syndromes. And we were thinking, is this a similar sort of situation? I unfortunately, I don't know anything about EMG at all, which is kind of embarrassing, but I am fairly junior, I suppose. But this was complete. I was way out of my comfort zone, thinking about this case in this detail and writing it up for this VMR. It was a case that so little of which I didn't understand, but has been so exciting to explore and has been a really inspirational case for me now, going on and pursuing my career. And again, just stunned and always just so impressed. And so I have always take away so many learning points from listening to you guys. So thank you for having me.
The pleasure is all ours, I think that people in the chat want to know when you're back next, because I think we'll the amount of learning that we get is unbelievable. And of course, I think the final diagnosis always opens us up to want to learn about something unusual, but I think that it forces us to learn about neurological localization, about the value of diplopia, about the limitations of EMG, all these things that I think we use on a day-to-day basis. And so I'm very, very, very grateful for you to come to share this case with us, and eagerly await and your next gift to this community. We really, really mean that. I really appreciate it. I don't know if anybody wants to be on Mo's shoes today with a lot of learning to summarize, but we'll hand the mic to you, my friend.
Thank you so much for an amazing case. Such cases actually inspire me to study more so that I can become a good clinician and give correct treatment to the patient. I think the correct treatment saved the patient's life in this case. So thank you for sharing that. If we start with the teaching points, the patient initially came with the diagnosis of Graves' disease, which was diagnosed a month back. So we were discussing that we actually need a confirmatory test to finally confirm this diagnosis, all the antibodies. And the patient was started on medicines, carbimazole and propranolol. So the side effects of these medicines should also be considered, since the symptoms which the patient is presenting now are acute, and the patient has started these medicines just some time back. So side effects of carbimazole, we definitely need to look out for agranulocytosis, and we can get a CBC with DLC to confirm that. Then we saw that the patient had acute neuropathy, as we are discussing. So what could be the differentials? Heavy metal toxicity, acute intermittent porphyria, AIDP, GBS. And then we were just discussing if it could be a central nervous system or a peripheral nervous system disease. With the presence of bulbar weakness and respiratory compromise, we considered that peripheral nervous system causes are more likely than the central nervous system. And then whenever we see a neuro case, it is important to localize because it makes us understand the case better. So the patient had lower limb weakness. We were trying to think what are the causes for that. So one cause could be lumbar disc disease. With the lower limb weakness, if we ask for numbness, tingling, bowel, bladder symptoms, radiating pain, then we can localize it to the back or to the spinal cord. So these symptoms are important to be asked. So the one cause at the back could be lumbar disc disease, or number two, it could be tumor in an unusual location in spinal cord or a degenerative disease. Ultimately, when we try to localize it, we realize that the cortical symptoms are absent in this case. The patient's sensorium is maintained, so brain could not be involved. So the localization was spinal cord and below. It could be nerve root, nerve, neuromuscular junction, and muscle. Spinal cord, we tried to rule that out because of the absence of bowel and bladder symptoms. Then we were starting to think about the presynaptic and postsynaptic diseases, the neuromuscular junction diseases, Lambert-Eaton syndrome or myasthenia gravis. But the absence of profound autonomic symptoms made us think that Lambert-Eaton could not be the cause. But we were concerned about myasthenia gravis, and in fact, the presence of recent propranolol intake and thyrotoxicosis could be triggering myasthenic crisis, which was a possibility. So we were thinking what could be our next step. So next step in a patient with head-to-toe neurologic symptoms and intact sensorium could be a lumbar puncture as well. Then we were also considering another differential, that is thyrotoxic periodic paralysis, which is intermittent sudden loss of muscle weakness, especially in lower extremities, and happens in the setting of hypokalemia. But electrolyte testing showed normal potassium levels. Then we were discussing about diaphragmatic weakness and what could be the consequences for that. It can lead to hypercapnia and acidosis. So we need to be in lookout for that, and we need a lot increased hypercapnia to make the patient hypoxemic. We have to see that properly because of the oxygen requirement of the patient, if the patient needs intubation or not. And then we realized that the patient had proximal muscle weakness. So again, the localization, it could be in muscle, neuromuscular junction, or nerve. Muscle has a high chance. When we have a proximal muscle weakness, the problem to lie in muscle has a high chance. But the presence of diplopia made us also think about NMJ, and the presence of atrophy in arms made us think about nerve. Ultimately, we found that EMG showed myopathy. And we started localizing it in the muscle. So we started to think about the causes of myopathies. It could be immune-mediated myopathy, inflammatory, or metabolic myopathy, could be endocrine. Empiric treatment we thought initially to be given of IVIG and pyridostigmine. And then we saw one of the antibody came out to be positive. We discussed that we know about MDA5, certainly it is the rapidly progressive one. And next step we thought about it could be MRI, muscle, and biopsy. Ultimately, biopsy was done, and we realized that the patient is having overlap between NMJ and muscle disease, leading to the whole presentation. So we had a constellation of symptoms with myositis, myasthenia gravis, and a thymoma. And we were also concerned that we need to look out for myocarditis as well. But that was a very amazing case. I'm sorry if I missed something or said something wrong. Thank you so much.
You absolutely nailed it. That was an outstanding journey. A recap of all the learning along the way. What a treat, y'all. Thank you for a very, very precious hour. I will never forget this. Huge shout out to you, Hugh, for another mesmerizing case, and big gratitude to Zachariah for scribing as well. And Mark and Anmol, you guys are absolutely amazing. Thank you. See you guys next time.
Thank you so much.
Thank you, Hugh.